Hello, everyone. This is Dr. Beavers, your INBDE coach. Every couple of days, I will post presentations for different conditions based on research, highlighting important points from our study materials and answering questions by the end of the presentations. So let's get started with the patient with asthma and dental erosion. Our 43 years old male with asthma is using corticosteroids and beta 2 agonists, and his chief complaint was sensitivity and composite discoloration. On clinical exam, we found saucer-shaped erosion on labial surface of the teeth and dry mouth. The management of this condition, based on the paper, was fluoride rinse, saliva stimulation, and diet modification. Pharmacology perspective for patient with asthma, we need to know that beta 2 agonists and corticosteroids reduce saliva, and the inhaler pH is lower than 5.5, which is causing enamel decalcification. And spacer use for this situation will help reducing drug contact with the teeth. Here, I found this picture on Easy Med Learning to memorize. We have beta receptors. Beta 1 is for heart because we have one heart, and beta 2 we can remember is on lungs because we have two lungs. And you can pause the video if you wanted to uh, memorize the rest of receptors. Pharmacology perspective for patient with asthma, we need to know that beta 2 agonists also cause relaxation of the lower sphincter, causing gastric reflux and um, teeth erosion. Oral pathology perspective, we need to memorize that enamel erosion begins below pH 5.5, and it's common in patients with asthma using inhalers. There is also loss of protective salivary components, including IgA calcium buffers. Also, exposed dentin will cause, of course, sensitivity and cosmetic concerns. And uh, in the future, in the next presentations, I will explain in more details the difference between erosion, abrasion, and attrition. We will need to understand them more for the exam preparation. For microbiology perspective for patients with asthma, we need to know that low saliva increase the risk of candida and streptococcus mutans overgrowth. IgA is important for mucosal defense, and it's reduced for patients with asthma or dry mouth in general. Xerostomia affects the flora balance, increasing the risk of decalcification. So fluoride chlorhexidine recommended in microbial control. For our patient education, we will focus on two main things. For oral hygiene, we will ask the patient to brush twice with fluoride toothpaste, soft bristled toothbrush, and using fluoride mouth rinse. For regarding the using the medication for asthma, we will ask the patient to drink plenty of water to avoid dry mouth, using also sugar-free gum to stimulate saliva, and avoid brushing immediately after inhaler to prevent more teeth damage. For a restorative perspective, it's common to see composite restorations discoloration for patients with asthma or dry mouth. Uh, for uh, for erosion subgingivally, we need to avoid beveling and cementum if there is erosion and subgingival. Also, after we finish the procedures or the restorations, it's recommended to apply fluoride after we finish composites and restorations. So let's practice some questions. I will go through the questions and let you answer it by yourself. Which inhaler-related habit would most increase enamel erosion in patients with asthma? Okay. A 43 years old patient with asthma using an albuterol inhaler presents with saucer-shaped labial erosions. What is the most likely cause? Okay. A behavioral intervention most effective for reducing erosion risk in patients with asthma is going to be okay. What is the primary mechanism of action of albuterol? Okay, and we reached to the end of the presentation. And if you're interested to practice more questions, you can follow me in Quora. You'll find the link in the description. And thank you for attending the presentation.